good afternoon. I'm Dr. Nitin Kapoor, Medical College Fellow. Over the next 20 minutes or so, I should take you through this topic of evaluation and follow-up. This is basically insights that are taken from the obesity clinic that we have at CMC Hello. And I understand that this is a post-lunch session, and sometimes, rather I say it's a post-grand lunch session. It's understand it's difficult to concentrate. We try our best so that all of you are awake at the end of the session, and it's more interactive with the Q&A time. So I thought I'd start with a question. For a minute, we cannot forget that we are all physicians, we manage obesity, we are patients. It's a simple question. So if I was to ask all of you, how much exercise we need to do to burn off an average serving size of French fries? Not a large French fries. I'm sure all of us at some point in our life will have French fries. And the answer is an average serving size of French fries will have about 600 calories. And it would take me 1.5 hours of swimming to burn that, or 3 hours of walking, 1 hour of running, 2 hours of bicycling, so forget about the exercise required to burn the grand lunch. But today we stand at a point where there's a gross mismatch between our diet and exercise. And even though the years have gone by, our view screens have become flatter, but bellies, amongst us, have become fatter. So we all are aware that obesity is a rising problem, and this is data from the Well-known Birth Cohort, one of the oldest birth cohorts in the country. And what we've seen that over the last decade or so, there's almost a doubling in the amount of obesity, especially in women, from somewhere between 30% to 70%, just in the span of the last 10 years. We've been following this birth cohort for the last 4 decades, and obesity has really increased. This is from India, but there is also data from the West, in the United States. If you look at the number of people with obesity, about a third of the population is obese. But what we are interested in, or what we are going to discuss in the next few slides, is this proportion of people who are morbidly obese, who have BMI of more than 35, and they contribute to about 15% of the population. So why is this so worrying? Why is this particular subset of people so worrying? And the reason is that when you look at the rising prevalence of people who are morbidly obese, the higher the weight growth, the more rapid the weight gain. So it was this line, which is BMI more than 50, that is the maximally rising growth. So it was almost 10% in every year. So that's why it's worrying, because this population is morbidly increasing, and that's why it is required in a country like India to have more and more such clinics. Now, we have a lot of literature from the West, but our patients and our society is slightly different, and we have to understand those differences before we get into the management of obesity. In India, we have people who develop complications like diabetes, hypertension, dyslipidemia at much lower rate than what we see in the West. We are a developing economy. We cannot afford to lose a lot of people with complications of obesity in their young age. When we talk about dietary interventions, whether it's North India, South, West, or East, all of our diets are very carbohydrate rich, very difficult to kind of change the state of carbohydrate diet. And the only effective therapy that we have today, that bariatric surgery, is not affordable to the masses. So we're really struggling with this kind of a scene that is there. So in the next few slides, I will talk about the perspectives, both from a patient point of view and from a physician point of view. We should be clear as to what are the objectives that we want to achieve in the obesity clinic when we manage a patient. We'll talk about the measurement of obesity indicators, try to assess how we assess the root cause of weight gain in a given individual, evaluate the comorbidities, management options, and most importantly, the follow-up. So we run this bariatric clinic, which is a team of 6 different specialists. It includes the endocrinologists, bariatric surgeons, nutritionists, physical therapists, pulmonary specialists, and the most important, the psychologists or the psychiatrists. It's a referral-based clinic, so we see only patients who are referred to us and who have morbid obesity. Just before I go on as to how we go about the structure of the clinic and what are the evaluation rules, I'll just show you the demographic details of this subset of patient database of about 550 to 600 morbid-obese people that are on follow-up. And the mean age of people that we see is around 37 years. Most people are in their late decade. A larger portion of them come from the state where we are, but people come from elsewhere as well. Contrary to the usual fact that obesity is a disease of the rich and well-educated, that's not true. About 46% of our patients are actually not so well-educated. 1/5 of our patients are actually unmarried, but amongst the married, 1/5 are primary infertility. Huge differences in rates that we see, but what I'd like to stress is health-related quality of life in these people is low. So majority of people have health-related quality of life of less than 50. So whenever a patient sits in front of you in the pediatric clinic, you have a lot of questions in mind. And many times the questions are similar. Patients would say that I've tried everything, doctor, but nothing is working. They just want a short medicine, they want a tablet that will reduce their weights, they'll ask about their target weights, they'll be worried about weight gain. They would blame it to genetics, they would say everybody in my family is obese, and that's why I'm obese. All these things will be there, but what the point I want to stress is that every patient that you manage with obesity is different. And you cannot have a blanket treatment or a blanket rule to treat each one in the same way, and that's what we need to identify. From a physician perspective, the objectives that we like to achieve in obesity clinic essentially is to reduce the overall risk, whether it's cardiometabolic risk, establishing healthy habits, and especially if the patient is planning for pediatric surgery, ensure that the patient is motivated enough as to commitment so that after surgery as well, the patient can do well. The first and the most important thing that you need to do in a obesity clinic is to assess the degree of obesity. And believe me, as simple as it sounds, it is not so. I come to this point in a couple of slides. The other important thing is to assess root cause of weight gain. I was lucky enough to visit Professor Arish Sharma's clinic in Edmonton. We talked about a decade back. And one very important thing that he really taught us was that with his background of nephrology, he compared obesity to edema. So edema is a symptom of different disorders. Edema could happen because of renal failure, it could happen because of heart failure, it could happen because of liver failure. But obviously, unless I identify which is that problem, I cannot really treat somebody with heart failure with liver failure, for instance, and so on and so forth. So what's the important thing is we have to find out what is the cause of weight gain. Somebody who's not really eating much, there's no point advocating that you have to cut down your diet further. We have to find out what are the causes, and then we talk about that in a while. If we evaluate the comorbidities, and believe they are not only the physical comorbidities that we need to talk about, it's a lot more, it's more psychological as well. We assess the patients regarding their nutrition, their physical activity, their psychological status, not only assess, but we also have to manage that. And the best part of managing obesity is not that you keep your management strengths with you, but you hand it over to the patient. You empower the patient, you tell them what you know, you tell them how and what they can do to reduce weight rather than you dictating this is good, this is bad. You educate the patient enough that they themselves start managing obesity. Because it's a lifestyle disorder, it should be managed on a day-to-day basis. The patient will not be with the doctor all the time. So they should be aware. We just help them, we just guide them which way they have to go. And obviously, whichever is the medical management or the surgical aspect, whether they are fit or not, or whether they have to go in for that or not, we decide. So what happens at our clinic after registration? We try and involve the patient as much. So there's a social worker who helps the patients to fill out the form, but we try and involve the patient as much as to get the basic demographic details. And then we go in for the anthropometric measurements. As Dr. has always stressed, these anthropometric measurements have to be very standardized. We ensure patient comfort is taken into account. There are different ways in which we can measure obesity. The most common, unfortunately, is the body mass index. There's also waist circumference. We can measure waist circumference. We can do body composition analysis and other fancy things that we have. We know that the WHO guidelines for BMI in Asians is less, and somebody in the US would be diagnosed to have obesity only if they have a BMI of more than 30, unlike in an Asian Indian, we would say anybody with BMI more than 25 is obese. But actually the world literature is moving away from BMI, and currently when we talk of clinically severe obesity, we are essentially talking about comorbidities that are associated with this obesity rather than just BMI. So BMI of 33 or 34 may still be as bad for another patient who has BMI of 40, may not be as bad. And it's simplified this in this example. Some of you would have seen this in a morning blog. So these are two patients which you saw in this clinic about 10 days back, and in the same clinic. So patient number 1 is a 37-year-old girl. She's got a BMI of 41.5. She's got borderline diabetes, the A1C is 6.2, predominantly impaired fasting glucose. She's not on any medications for that. She's got normal blood pressure, very borderline cholesterol levels, for which she's been advised lifestyle changes, and on ultrasound, she's not got any fatty liver. So in short, this patient is about 37, morbidly obese, and borderline metabolic problems. We look at patient 2. She's almost similar age, 36-year-old. She's got a BMI of 43, which is also similar to the previous patient. But when you look at her diabetes, she's just recently diagnosed a week back to her diabetes. A1C is 9%. She's already started on lifestyle modification of metformin since the past 1 week before she came to us. She's already on antihypertensive. She's got dyslipidemia, which is totally under control. She's got grade 2 fatty liver. So almost two same patients, two similar age groups, same sex, similar BMI, but a cross difference in their metabolic profile. We went ahead and did their body composition. This is done by DEXA scan, and we compared the body composition results of these two patients. When you look at the BMI, it's almost similar. When you look at body fat, actually patient 1 has more body fat than patient 2. Okay, so present. But when you look at the visceral adipose tissue, patient 2 actually has much higher visceral adipose tissue than patient 1, almost double. And this is probably the reason. So again, I'm saying it's just not the BMI that is important. It's all these other comorbidities that are very important that will help you decide what's the best management for that patient. You need to be really aggressive, and this patient actually has to plan for very aggressive. So after basic anthropometric measurements, we move on to the individual assessment by the team. So this is done by 6 specialists. And even though they see the patients individually, we have a once a week multidisciplinary team meeting where the patient is not there, but we discuss, each of us sit in a conference room and discuss each patient that we've seen that week and document what each of us feel, and then we have a combined plan. And really that really helps in the long-term management of that patient. So once you have a patient with severe obesity that we've done the anthropometric measures, we move ahead and assess the root cause of weight gain. And as I said before, it is important to identify what is really cause weight gain in them, whether it is just slow metabolism, whether it is more of dietary problems, or whether it is more of physical activity related problems. This is data from our center. What we found was most of our patients actually take a lot of fat, and the fat content really matters in your clinical practice. Ask patients as to how many members stay at home and how much oil you get in a month. Tell that an average diabetic obese patient should take about 500 ml per head or oil per head per month. Patients are really surprised. You get more surprising answers when you actually talk. So fat are very high protein content is usually less. There are pediatric nutrition guidelines for India. Essentially, the fact is that patients should eat their food on time. They should ensure that the normal recommended protein intake is definitely more important in patients with diabetes. Keep watch of the body content, monitor the calories, but most important thing, whenever somebody has lost weight, as Harishana mentioned in the morning, they just died obviously in remission, and their body is trying hard for them to get back to their usual weight that was initially there. And until this, you have a regular follow-up. It's a lifelong follow-up, and that's something very, very important. The importance of protein. This was a small project that we took couple of years back, where we gave diabetic patients same calorie food, but we just ensured that the protein content in the food was as per the recommended guidelines, and we found that even if somebody takes just exactly the same calorie food, the glycemic surge is much less if your protein intake is that what is normally recommended. We didn't give high protein diet, we just give normal recommended protein diet as per the IDEC guidelines. Exercise again, it's not that one size fits all. You may have an elderly lady with osteoarthritis. You obviously cannot ask her to walk 5 kilometers every day. Which is not possible. You have to tailor it. You may have to ask her to walk minutes 3 times a day, maybe that's just 30 minutes of walking that she can do. We need to assess as to what the patient can do, how much the patient is motivated. Patients usually have ready-made excuses. Doctor, I'm so busy, I have no time. I don't like walking. And manage these individual factors. You should have ready-made answers for them right at onset. Another important cause of weight gain that you need to assess is medications. A lot of our obese patients have a lot of comorbidities, and we should ensure that whatever medications they are on, they are not increasing their weight. Medications for diabetes, cardiovascular disease, we have those medicines which promote weight gain, but at least we should try our patients to have medicines which are weight neutral or those which promote weight loss. And it's not only for diabetes, cardiovascular disease, many of our patients who have allergies, inflammatory disease, depression, a lot of antidepressants cause weight gain, and antipsychotic drugs cause a lot of weight gain. So we should ensure most of our patients are on drugs which are either neutral or which promote weight loss. So after we have done with the assessment part of why the patient has weight gain, the next important thing is to try and assess the comorbidities. And believe me, it's not only the physical comorbidities that we're actually worried about. As of today, there are 236 comorbid conditions that are described with obesity. And what we're worried about, apart from the mechanical and the metabolic problems that the patient has, it's also very, very important for you to assess the psychological or the mental part of this framework. And believe me, this is data from our literature, from IDEC, and we found that 1 in every 3 patients who actually attend our clinic have a psychological diagnosis, need psychological counseling or treatment in some form or the other. So even if you don't have a pulmonologist or you don't have a physiotherapist and you guide the patient on exercise, you cannot do in an holistic clinic without a psychiatrist or a psychologist, especially if you have a good load for patients who are going for pediatric surgery. The psychologists are not only to diagnose these psychiatric disorders and treat them, but they have a lot more role. And especially talking about history of eating disorders, so we found in our patient, a lot of our patients actually have something called as night eating syndrome. They tend to snack a lot at night, and unless we really identify these problems, no matter how much diet and exercise and how much medical management we suggest to the patient, we won't really pick it up. So we have to, psychiatrists really do a good job in setting real goals, realistic expectations. They assess the willingness of the patient to actually change weight, and a lot of these patients actually have substance abuse, and most of the anti-obesity drugs that are available have psychiatric problems, and that's why it's important to assess that before starting. We suggest that whatever evaluation that you do should contain standard questionnaires, like for somebody who's got problem with sleep apnea. It's always good to use a validated tool. I mean, it doesn't take just about 5 or 6 questions that we have the Everett sleep scale, but at least you would know whether you need to go for a sleep study or no, whether this patient is probably having sleep apnea or not. So as long as you have these validated tools in place, it makes much easier your management. As I told you before, that quality of life is also very, very important in these patients, and what we found was as the BMI quadriles get worse, so as the BMI gets worse in each of these quadriles, even though the health-related quality of life comes down, but the components, individual components of health-related quality of life that contribute are different. Somebody who's very, very obese is more worried about the physical impact or the psychological impact in them, rather than those who are in the intermediate quadrile 3 would be more worried about their comfort with food, and they are more disturbed about the experience of dieting. So quality of life assessment is also something that is very important, because sometimes it's not just changing the weight in kilos, but if the quality of life of the patient is improving, you're still doing a lot of good to the patient by obesity treatment. After we set an initial target weight, we tend to do investigations, and the investigation profile should be ideally complete. About 5% of our patients actually had exogenous steroid-induced solutions, and they would say that they have never taken steroids in any form, and they would be taking some powder, some salad, somewhere they've got this for their knee pain or asthma. And it's only if you assess their life would you actually pick up these abnormalities. So once you've really had a complete assessment done, we suggest medical management. Lifestyle management is the first thing that we suggest. stop. The medical therapies for obesity, even though there are 5 drugs approved by the US FDA, in India we just have a broadest pact, suboptimal dose of liraglutide. Locazepam is available in about 10 to 15 centers in India. It's a clinical trial, and I think that's about it. So the medical therapy aspect of obesity till now in India is not that great. We now reassess the patient at 3 months, and after reassessing, we see and we talk to the patient about bariatric surgery as an option. And it's not the patient who decides alone that he's wanting to do the surgery, it is our team's decision. Even though the American Society of Metabolic and Bariatric Surgery has guidelines of BMI more than 40, for those who don't have comorbidities and BMI more than 35 with comorbidities, there are different Indian and Asian consensus guidelines which have much lower BMI, as low as 37 and 32, even as low as 27. But again, the important thing is it's not the patient comes to you and saying, Doctor, I want bariatric surgery. It is your team that needs to assess and ensure that this patient is absolutely fit for surgery. So it is the onus is on us to decide which surgical procedure would suit that particular patient, depending on their age and other comorbidities. And we should have a medical plan. And the expectations of bariatric surgery should be made very clear to them, right at the first instance when we discuss. And we know that the weight loss is there in the initial year, but there is some weight regain as we discussed in the morning. The patient should know what exactly are the benefits and the risks that are involved in the surgery, and the patient should be fully aware about all of it. Also, those who are not fit for surgery or not willing for surgery, what we practice in our clinic is mainly knee replacement therapies in the low-carb diet. There are different knee replacement powders that are available in India. First is not as commonly available now as it used to be about 5 years ago. But there are others. But the only word of caution is there will be medical representatives who tell you, Doctor, this powder is good, but what you need to see is the protein content. And at least 20 grams protein is something, 50 to 20 grams protein is something that will actually give you good satiety. You need to replace one meal with a powder to cut down and bring about a very low calorie diet. There is literature work coming up from this group, Mr. Roy Taylor. They said that with diet alone, you can achieve what is achieved with bariatric surgery, and reversing diabetes is possible. Well, that's something that's still work pretty much in progress. Just a word about follow-up. So there is poor adherence, and at the end of it, patients do regain weight, and this could be attributed to the biological problem or the adherence. And what we as physicians can do more is about the adherence, but we cannot really do much to the hypothalamic injury, which Dr. shown in the morning. So, at the adherence part, how do we tackle that in our clinic is obesity support groups. So, we have a monthly meeting for all our morbidly obese patients who come on Sunday morning, and they interact, and we have a very good interaction where people share their own experiences. They share amongst these other patients how they have achieved the weight loss, what they feel about it, and they have their own WhatsApp groups. And I think that is something that gives them a good social binding, that there are more people like them, and they travel and fight this journey of obesity together. So just to conclude, in an obesity clinic, we would say that, sorry, so now the slides bring down. So just to conclude, the first thing is that patient management should be, the patient should be given the onus for treatment rather than you taking that onus. We assess obesity by different parameters. It's time we move away from BMI. We set a target weight which is not the ideal body weight, but something that's more achievable. Our evaluation for patients with obesity should be complete. And for those who are not able to afford bariatric surgery or not eligible for bariatric surgery, as of now, we need replacement therapy or restricted feeding